Welcome back to the second half of pharmacokinetics. In this block, we'll talk a bit about one and two compartment modeling of drug distribution and elimination. To some extent, we've already hit on some of these points, but we didn't use that terminology with you. We'll talk about an understanding of how repetitive drug administration or continuous infusions of drug impact on drug levels and also on achieving this concept known as steady state, where the amount coming in the body equals the amount leaving the body. We'll talk about the concept of half-life, which is true for almost every drug we use in practice. We'll talk about how the pharmacokinetic parameters affect the time course of drug action. We'll talk about the difference between zero and first order and saturation kinetics. That'll become more clear in a bit. And we'll talk about a number of the parameters regarding loading doses, maintenance doses, and refresh some of the terms we've used earlier, and then finally talk a bit about individualized responses to drug therapy, factors that affect drug response. So if you remember how we left the last time in pharmacokinetics, we differentiated what fell in the domain of pharmacodynamics and what fell in the domain of pharmacokinetics. Pharmacodynamics, we primarily focus on drug action at a receptor site. And when a drug binds to that receptor, we expect a response, usually, either toxicity or efficacy, at least in the case of an agonist. In the case of an antagonist, we might see just blunting the specific effect that would be seen if that receptor were occupied by an agonist. The concept that we are talking about here is pharmacokinetics, more or less how drugs get to the receptor and how they ultimately get out of the body, and where they go in the interim. That's really pharmacokinetics. So let's now, that we've gone through drug absorption, distribution, metabolism, and elimination, let's now talk about a concept that is seen in almost all drug action, something called first-order elimination. And we'll look at giving a single dose of a drug that behaves this way. First-order elimination, another term for this is concentration-dependent elimination. So here we're looking at how a drug, we talked about how a drug is absorbed in a concentration-dependent way, usually how a drug might be metabolized, sometimes in a concentration-dependent way, and that would be true if there were an infinite amount of an enzyme available, or at least the amount of enzyme exceeded the need for it. And in that case, the more drug that's available per unit time, the more drug that gets metabolized in that unit of time. So we'd see drug absorption being concentration-dependent usually, drug metabolism usually concentration-dependent process as well. Drug distribution is often concentration-dependent, that the drugs crossing membranes and being distributed, more specific drug gets metabolized per unit time in the first unit of time than the second or third, depending on the amount of concentration of drug. And finally, in this case, elimination of drugs is also concentration-dependent in almost all cases. So let's look to the graph at the left. The graph at the left is the drug plasma concentration on the vertical axis, and the horizontal axis is time. And the classic example here is a drug that will be eliminated after we've given the drug. We start the clock after the drug's distributed. So typically, imagine in this case we gave the drug at 0 hours and gave it IV push, for example, over a few minutes, and then by 1 hour, all the drug that was in the central compartment had distributed where it's going to go, and we now have drug in equilibrium between the tissues and back in the bloodstream. So we start the clock about 1 hour here, and what you'll notice is that at 2 hours, the level goes down to 8, and at 4 hours, the level is at 4, and at 6 hours, the level is at 2, and at 8 hours, the level is at 1. What's happening here is classic concentration-dependent elimination, that at the same unit of time, 2 hours, in this case, half of the drug is gone. In that first 2 hours, from 2 to 4 hours, we see more milligrams of drug gone than in the second to the from the fourth to the sixth hours. But we still see 50% of the drug disappear in that unit of time. That is classically what we see as the concept of half-life. Half-life is defined as the amount of time it takes for 50% of the drug to leave a particular area. And usually when we say half-life, we usually are referring to the concept of elimination, drug elimination half-life. If I take the same data, those same points on that curve, but instead graph it in semi-logarithmic graph paper, you may remember using this type of graph paper at some point in math, that the concentration of the drug over time becomes a straight line. So if we take the logarithm of those points on the curve, lo and behold, classically what we see is a straight line or a slope of that line. And the steeper that slope is, the more rapid the drug is being eliminated. So you could well imagine that we see the same, really it's the same data. If you look, we see the level go from 8 to 4, 4 to 2. Just keep in mind that that axis, while it isn't on the vertical axis on the logarithmic y-axis, that in fact is not marked in logarithmic ways, but in reality, that would reflect a logarithmic depiction. So biologic half-life is determined as the amount of time it takes for half the drug to be removed or from a particular area. And usually we think of this as elimination half-life. So for example, if we have 1,000 milligrams of ampicillin and we give a dose, we expect if the half-life is 2 hours, then after 2 hours of administration and the drug is distributed, we'd expect 50% of the drug level in the bloodstream or in that compartment to be gone, and then another 50% gone in the next 2 hours and then the next 2 hours. Some drugs have a long half-life, 24 hours, 48 hours, 72 hours. Some drugs have very short half-lives, 5 or 10 minutes, some drugs. So the half-life is an important consideration, and the half-life is determined both by the drug and also by the patient. So for example, for a healthy patient, ampicillin half-life is typically going to be 2 hours, but because ampicillin is eliminated solely in the urine by glomerular filtration, for someone who has poor renal function or is in renal failure, the half-life might not be 2 hours, it might be 8 or 10 or 12 hours. Because their renal function is not very good. So the same data that we saw in an earlier graph is depicted again here. Imagine that we start the clock after the drug has distributed. That first initial drop that you see on the graph is usually, that steep drop is related to drug distribution. But then we'd see a level, for example, of 102 hours, a level of 54, a level of 26, a level of 8, a level of 12 and a half and 8 hours. And so here's an example of ampicillin having a half-life of 2 hours. We take that same data and put it on semi-log graph paper, and lo and behold, we get a curve or a straight line that looks like this. This is, again, the slope of that second downward line is the elimination slope. What we didn't really talk about, we'll come back and talk about in a little bit, is you'll notice that the level got quite high and then it fell off rapidly after the first hour or an hour and a half after the infusion ended, and then the slope of the line got less steep. That initial steep slope represents the time the drug is being distributed through tissue. And so that very steep decline is in fact, represents the half-life of drug distribution. We call that sometimes the alpha half-life. And the lower slope to the right is considered a beta half-life or the elimination half-life of the drug. When you hear someone talk about half-life of a drug, they're almost always referring to the elimination half-life, how drug gets out of the body. So drugs with a short half-life, if we're going to keep levels up, we have to dose them more frequently. And the half-life is often longer if the drug is eliminated in a means like hepatic or renal in someone who has hepatic or renal dysfunction. So this distribution, we referred to the alpha half-life a minute ago about the distribution half-life. Most commonly, we consider the elimination half-life the beta phase or the beta half-life. And the slope of the line of that semi-logged graphic is considered the elimination rate constant. So let's use a couple of terms here that you may remember from when you had algebra. You may remember the old expression of y equals mx plus b, where you were graphing different points on graph, and you were looking at the slope of the line. You were looking at the concentration at time 0, or b, the intercept and the y-axis. All of these sort of relate to this concept. We'll come back to this in just a moment. But the half-life is directly related to this elimination rate constant in a formula that's is a constant number divided by this elimination rate constant, or the slope of that line. Let's look at this in a more, maybe a little bit easier to understand, is that when we have a drug, almost every drug behaves in this concentration-dependent elimination way. The first decay of the drug, which is a steep decay, is called sometimes the alpha half-life or the distribution half-life. The second, slower decay of the drug out of the body is the beta half-life or the elimination rate half-life. And almost always we will look toward or be interested mostly in the beta half-life. The alpha half-life, the only important issue with the alpha half-life that you have to keep in mind is if you're getting drug levels, particularly 2 drug levels, a quote-unquote peak level, which we don't do very often, and a trough level, which is the lower point level on the curve. We want to make sure that both of those levels are drawn in the beta half-life window of that drug. That distribution has been complete, because we're going to draw a line between those 2 points on a curve to find useful information. And lest you feel overly fearful, you as a mid-level provider probably won't be doing that. Who will be doing that is the clinical pharmacist that may be working on your inpatient team. And even we as clinical pharmacists don't do that often, but it is sometimes helpful to look at the behavior of a drug, and when a level is going to get within a range we need to know for redosing for a patient who's responding in a way we didn't typically expect. Typically we'll see this, for example, and pharmacists will do this calculation of 2 points on this beta curve for a drug like vancomycin in a patient who has renal failure. So, for example, the patient had a dose of vancomycin 2 hours ago, or maybe 8 hours or 10 hours ago, and they have a point, they get a lab drawn and the level is high. And so the team wants to know, well, when are we going to redose that drug and at what dosage? So, well, if the level comes back at 28 and the person's kidney function is poor and the level of 28 is high, then typically what we're going to say is let's get another level in 8 or 16 or 24 hours, and then have the pharmacist measure the distance between these 2 points that are both on this beta half-life curve, and then calculate for this patient what that individual patient's half-life is for this drug. So first order elimination has the concept of half-life. Basically, half-life doesn't matter what the dose of the drug is for first order elimination drugs. Half-life is half-life. So whether the dose is huge or whether the dose is low, classically what you'll see is that half-life for that patient is half-life. If their kidney function is stable, if we haven't saturated some process, that if the half-life for ampicillin for this patient is 2 hours, then whether the dose is 2 grams of ampicillin or 500 milligrams of ampicillin, whether it's an hour after we gave the dose or 8 hours after we gave the dose. Whatever is left in the bloodstream, it's going to drop by 50% in 2 hours for that patient, as long as their kidney function stays the same. So the concept of zero order elimination is that there's a concept of half-life, and half-life doesn't depend. There are some other formulas here. I don't think you need to get overly concerned about those formulas, but there are some concepts that relate to each other. And what is more important here is just to have a fleeting appreciation for how they relate to each other. So a clinical pharmacist would be more familiar with these formulas and use them, but clearance represents the volume of blood from which all drug is removed in a unit of time. We already sort of addressed this issue as far as creatinine clearance. How many mils of blood are cleared per minute of creatinine? So that would be creatinine clearance. Well, clearance is a function of two variables. One is the volume of distribution, which we alluded to earlier, basically how much drug is in the body, how big of an area that you have to clear. It's also a function of the slope of that elimination line that is related to half-life. And clearance really, it can be, for some drugs, more than just by one route. Some drugs mostly get eliminated by renal elimination, but they may also have a little bit of drug metabolism that happens in the liver or somewhere else. Some drug may be secreted directly into bile. Some may be blown off by respiratory in the lungs, or excreted in sweat or saliva or something else. And so the total body clearance is a sum of all of the ways that the drug will get out of the body. In clinical practice, there really are only two important ways that most drugs get out of the body, and that is either by the kidney via glomerular filtration and to some degree maybe tubular secretion, but mostly glomerular filtration, renal, and or the drug is metabolized, sometimes the liver, sometimes other places, to something that is not pharmacologically active. And so those are really the two major components of drug clearance, and that varies by the drug. We've already alluded to the drug ampicillin, the antibiotic ampicillin. Its elimination is all renal. There's no other elimination but renal. Most of the drugs that we have in practice in neurology and psychiatry are mostly metabolically eliminated, or would consider this hepatic elimination, where the drug is chemically converted to something that's inert. So we'd consider the drug cleared when there's no more pharmacologically active drug in the body. Now, truth be told, the metabolite that is not pharmacologically active, the product of that metabolic, the result of that metabolic process, may still be floating around. And so that really isn't out of the body. But if it's inert, if it doesn't do anything, ultimately that will likely, if it's more water soluble, get out of the body via the kidney. But we almost don't worry about that because it doesn't do anything. Okay? There are some variables here that are related to each other. You don't need to know these formulas, but half-life is related to elimination rate constant with a standard 0.693 constant. But we can substitute other variables that we know with the clearance formula and do a little algebra and move things around a little bit, and you can see that all these factors are interrelated. And so the sense of putting these formulas around clearance or down is that clearance really is a function of the elimination half-life of the drug and the volume of distribution of the drug. Okay, what we represented with first order elimination represents 99+% of the drugs you will use in practice. There are always exceptions to every rule, and here is an exception where we rarely see a drug that undergoes zero order elimination. Zero order elimination is when we have somehow saturated a process. Most often we see this when drugs require metabolism to something that's inert, and we have used all of the enzymes that are available to metabolize that drug or that substance. And so, or maybe the elimination is a function of tubular secretion or something else that is a rate limiting step. In any event, it doesn't happen very often, but it sometimes happens with high doses of some drugs, particularly the three that you'll see in practice where this does happen is this anticonvulsant or antiepileptic drug called phenytoin or Dilantin at high doses. We also see it with high-dose aspirin, and we see it with alcohol or ethanol. And so each of these, we have this zero-order elimination process, and this can become very significant. And what's different about zero-order elimination is that the concentration in the blood decays by a certain volume or amount every hour. It's not 50% drop every half-life because there's no such thing as half-life. Instead, with zero-order elimination, we eliminate 20 milligrams of the drug every hour. So it goes down from 50, 48, 46, 44, 42, 40, not 50, then 25, then 12.5, then 6.25 in a concentration-dependent way. This zero-order elimination is classically seen when some system is saturated. The most common presentation, though, we'll see with a drug that does exhibit some zero-order or non-concentration-dependent elimination is that up to a point, once that system is no longer saturated, the drug elimination behaves like classic first-order elimination and has a curve that looks like this. So here, for example, might be someone who has an overdose or has taken too much Dilantin or phenytoin. So if we had given a huge dose of phenytoin that was too much, which we wouldn't hopefully do in practice, what you'll see is first this alpha phase, like we saw with the first-order elimination here in zero-order elimination. You'll see the alpha phase of the drug being, the drop being representative of the drugs being distributed. We'll have the zero-order beta phase or elimination that is a straight line, and this is not logarithmic, this is just standard numbering in the vertical axis of this graph, that you eliminate X number of milligrams of drug per hour, not in a concentration-dependent way. So this could be someone with a Dilantin level, say, of 40, and then after 4 hours, the level is 36, and then 4 hours later, it's 32, and then 4 hours later, it's 28. And then as you go on, it just, you get to a break point where those enzymes are no longer saturated, that you have more enzymes available to metabolize a drug. Then it behaves like a classic concentration-dependent elimination. And what you'll see is a beta phase and a first-order elimination. And for the drug phenytoin, this happens somewhere when the level gets around 25 milligrams per liter or so. So the time course of drug action, whether it's zero or first order, and most often it is first order concentration dependent elimination, is all going to be like the same issues we saw before. The elimination profile is going to be a function of the concentration of the drug, and there are going to be drug factors and patient factors that impact that. So as we're looking at the whole time course of drug action, the things that are going to impact how the drug is going to move around the body, getting in and out, is going to be a function of how fat soluble the drug is, what its molecular weight is, does it get and distribute to different tissues, is there a process of eliminating it through the kidney, or is it metabolized? Those are all drug functions that are going to impact that. But layer on top of that, that for individual patients, their GI tract function, their perfusion function, their volume status, their renal function, their hepatic function, their genetic composition, all of those are going to have an impact on drug action as well. So classically, you'll see we give a drug intravenously, for example, the levels will get high, and then we'll see a rapid drop-off and then a more slow drop-off over time. Once the drug is distributed to its appropriate sites, then it's eliminated. You'll see with intramusculars, we alluded to a similar oral, a similar pattern, but a longer delay till we start to see elimination that's overlaid by the absorption and distribution of the drug. So with repeated dosing of a concentration-dependent elimination drug, which is the great majority of drugs we use, there's a concept known as steady state. Steady state is, with repeated dosing, ultimately the rate of drug input equilibrates with the rate of drug output. This is only valid for a concentration-dependent first-order elimination. But steady state, where we consider at least almost always the rate of input equaling the rate of output, is considered 4 to 5 half-lives to reach that point. And that becomes important because when we start somebody, for example, on a drug where we want to get a drug level, we're going to want to get a drug level at a point when we know the drug has equilibrated in and out of the body, that we don't want to get a level too prematurely because it's not going to tell us very much. So we're going to wait till we've reached steady state usually before we get a drug level to know that we've achieved a therapeutic level. So for example, with a drug like carbamazepine or Tegretol, which has a half-life of almost between a half a day and a day, we're going to wait 5 half-lives or maybe 3 or 4 days before we get a level. With a drug like phenobarbital, a longer-acting barbiturate anticonvulsant, where we would also want to get a level, we may want it, knowing the half-life is something like 3 days, we may have to wait up to 2 weeks. 5 times 3 is 15, 2 to 3 weeks before we're going to see the amount going in the body equals the amount going out. So the half-life and the concept of steady state is important to know when to draw levels on a patient who needs a certain drug at a certain time. If we were to start a continuous infusion of a drug, 100 milliliters per hour of a drug, that it would take 5 half-lives of that drug before the levels equilibrated and the levels remained the same. That's also true if we gave 200 milligrams per hour of the drug as a continuous infusion. It's going to take 5 half-lives before that line levels off. You'll notice it took the same amount of time, whether it was 100 or 200 milligrams for that line to level off. The level was higher with 200 milligrams than it was with 100 milligrams, but the point in time it took when the amount going in the body and leaving the body equilibrates is classically known as 5 half-lives or steady state. The same concept is generally true when we stop the drug. So we've given a continuous infusion, and then after some point in time, we stop that infusion. When we stop the infusion, we're going to consider that virtually all the drug is gone after 5 half-lives. Now, theoretically, it mostly is gone, but there's a little bit left. But we consider 5 half-lives from a practical point of view as virtually all the drug is gone. And so from a practical point of view, that's generally good enough for all of us. If we increase the dose, so we go from 100 milligrams an hour to 200 milligrams an hour of a continuous infusion, from the point we increase the dose to 200, we have to wait 5 more half-lives before the level is going to equilibrate and be the same level that we draw each time we draw that level. All of this assumes that the patient's elimination process, be it kidney or hepatic function, has not changed. If the patient's kidney function gets worse, for example, the patient in the intensive care unit has had hypotension and ends up with kidney failure, then all bets are off. They will continue to accumulate the drug as long as their renal function is not stable. So typically in practice, we'll give an initial dose. Sometimes we give a big initial dose so that we get enough drug at the receptor to do what we want. The problem with these kind of loading doses is that if we need to get above a certain drug level to get the therapeutic response we want, and in this graphic it's that green horizontal line, then a single dose got us there but didn't get us there for long. It fell off quite a bit because we had some drug being distributed to other tissues, some of it's also being eliminated. If instead we gave repeated doses of drug, then we end up with a squiggly line that looks like this, and we have to wait a period of time before we even get our first over the green line point, and we only get it for a little bit. In practice, if we give a loading dose plus a maintenance dose, typically what you'll end up with is a curve that looks something like this red line here, that the level will get up and then the repeated doses will continue to add to that. Keep in mind, though, it is still going to be 5 half-lives before that level on the far right becomes equalized. Granted, you got where you wanted to be at your goal level much earlier, but you're really not officially at half-life in steady state, until you get far out, 5 half-lives out into therapy. The plasma profile of a drug, it's sort of listed here. There's a couple of things on this graphic that I encourage you to think about. First of all, there are 2 horizontal dotted lines that are noted here, and these are what we classically consider the therapeutic window. That's the drug levels that are associated with the therapeutic benefit we're looking for. So classically in practice, we're trying to keep the drug levels within that window for the entire dosing interval. Too low and we don't have the activity we want, and too much we could potentially have drug toxicity. So what we'll do is we'll give the drug and repeated doses of the drug to maintain levels within that window. The highest level we have is the peak level. Now, in practice, we don't get peak levels because we don't know whether the timing of them is so difficult. We don't necessarily know that we really want a post-distribution peak level. We really don't want it when it peaks, when the infusion stops. We want it when the peak, when the drug is distributed where it's going. And for oral drugs, the overlapping time of drug absorption and drug distribution render it very difficult to get to time a peak that's even meaningful. In clinical practice, what we often will get is a trough level. Trough level is the lowest level or the level before the next scheduled dose. And a trough level helps guide us to say when it's time to redose the drug. And so that's really what we're going to shoot for most of the time. And really, of all the drugs we use in clinical practice, we probably only get drug levels on maybe a dozen drugs, and only when the levels provide us something meaningful in guiding our dosing or a therapeutic or evaluating the therapeutic response of a drug. But it's not all that common that we actually get drug levels. Factors that influence the action of drugs, we'll see things like age, body mass, gender, genetics, pathological states, physiologic factors, psychological factors are all influencing drug action. And we've kind of talked about those already. Age, and we'll talk more about this later in the year, but clearly renal function, drug absorption might be a bit different related to whether the patient has other factors. For example, a patient with diabetes may have slower gastric emptying time, which could affect the time course of drug action. The patient's body mass, a 50-kilogram little old woman and a 130-kilogram muscled football player who is much younger, have much different body masses, and so really require different dosing of drugs. There's some gender differences with drug action, not too many. Most of it has to do with the balance of water and adipose tissue. That might be different in general, but actually, truth be told, there's probably more variation within each group than there is between the genders. So that becomes less of a real issue in practice. The pathological state clearly has an impact. The biggest one we're going to worry about is renal or kidney function and how drugs are eliminated. But you'll find that's also that other disease states that clearly affect pharmacokinetics and action of drugs include heart failure and liver dysfunction, as well as a few other situations that come to mind. Psychological factors sometimes have an impact on drug action. The biggest one is the placebo effect. And it's true that if patients feel good and have good energy, that actually their response or their symptomatic response often is much better. And so it's important that we kind of do whatever we can, no matter what we do, to encourage the patient to have faith and trust in what we're doing, and really do it in a way that is ethical and appropriate to do. Finally, a lot of genetic factors, and we'll talk more about that a little bit later this summer and throughout the year. There are genetic factors that influence pharmacodynamics, so how drugs work at receptors, and there are genetic factors that affect pharmacokinetics, particularly drug metabolism. So we alluded to factors of age. Some of those are listed here. We talked about body mass. Those factors are reiterated here. We talked a bit about gender, but probably doesn't make as big of an issue. Pathological states, particularly renal function is the big one here. Psychological effects and belief systems are important in patient response. And recognizing a wide variation in individual response, much of which is affected by either the pathological states of the patient and or the genetic factors that affect those responses. And as it's related to that, the genetic factors are dramatic. We often consider genetics as a major player in how patients respond to drugs. And so this can be either related to pharmacodynamics and receptor sites or pharmacokinetics related to the movement of drugs. It can also relate to the development of toxic metabolites, and so it relates to drug toxicity as well. So this concept of pharmacogenetics, or the impact of genetics on drug action, is variable. It's been recognized for really 30 or 40 years and has really come into its own. There's lots of different references evolving for this. Here's a United Kingdom reference listed here on this slide, but I encourage you to go to many slides to find the nature of pharmacogenetics. There's lots of stuff online that will sort of steer you in that direction. The things we think about is that about genetics and disease. Certainly, genetics predisposes to certain types of diseases, and while we may or may not get the genetic information from the patient, part of our assessment involves getting a good family physical history, and their family history is, in a sense, is a clue to their genetic predisposition to certain diseases. It's also quite common in practice now that genetics is used as a determinant for very targeted drug use and drug response, and this is particularly true in oncology, where many of the newer therapies that we're using now, the modalities we've used over the last decade, are now targeted to a specific genetic predisposition on that specific cancer cell. So what we're trying to do is to differentiate how that cancer cell and its genetic information are different from that human that cancer cell is in, and so we can target something that's weak to weaken or destroy something specific on that tumor without harming the patient. We'll also see that genetics plays a role in many conditions, neurology being one of. So if we look at pharmacodynamic issues, we'll see that the receptors where drugs work are genetically influenced. And so we'll see certain drugs will work better in folks with some genetic predisposition and will work less well in others. Here's a few examples of them. We'll see differences in receptor quantity and receptor configuration, maybe in the intracellular proteins that react in the receptors. Here's some examples. There's genetic variation in beta-2 adrenergic receptors. This becomes important, among other things, for pulmonary drugs. So when you work in the emergency department with someone who has asthma or COPD, a bronchoconstrictive airway process of some sort, and we go to give them a beta-2 agonist, most patients should respond to that beta-2 agonist. A few patients won't. And so it may be hard to predict who won't respond to that, But one of the reasons why we give a second drug at a different receptor, at the muscarinic, the anti-muscarinic receptors, at the same time to augment that effect, is because we recognize that not everybody may respond to that first therapy. And that's primarily genetically related. A whole class of commonly used first-line drugs for hypertension and heart failure, the angiotensin-converting enzyme inhibitors, also the angiotensin receptor blockers, work very well for many patients, but certain patients they don't work as well, particularly folks who have a heritage from Africa often have a reduced response. So blacks in America may or may not have a variable response based on their genetic predisposition. And so many times we find that if a certain patient doesn't respond to an angiotensin-converting enzyme inhibitor for hypertension or heart failure, we consider an alternate agent and recognize that their response is probably pharmacogenetically determined. Dopamine receptors and their site of action for antipsychotic drugs, we'll talk about later in the year, are genetically influenced. The factors that affect clotting synthesis, platelet function, are all the Coumadin response to Coumadin or warfarin, highly genetically influenced. And so we see wide variation in genetic response to drugs like Coumadin or warfarin. Serotonin receptors that are involved in antidepressants or treatments of nausea and vomiting also vary with based on genetics. And so examples of these might see that it's not surprising even if you didn't know the genetic impact of the patient. For example, if you're going to select a particular serotonergic acting antidepressant and you knew that depression ran in the patient's family and there was one specific drug that worked for this patient's family member, that is logically probably the first drug you'll go with because of the pharmacogenetic variation seen. So if you know that that family member has tried 4 or 5 different antidepressants and the only one that's helped them is drug X, then you're probably your first choice for that family member you're treating now of that original patient should be the same drug, and recognize that variation is important in your predicting of their drug response. Genetics also has a wide influence on the cytochrome P450 enzymes that metabolize drugs. One common issue is the drug codeine. Codeine, actually, the FDA, Food and Drug Administration, is really looking toward probably eliminating codeine from the market. They've already put warnings on codeine in pediatric patients, but here's why. Codeine is metabolized by one of the cytochrome P450 enzymes, 2D6, to an active compound, morphine. The problem is that there's a lot of variation in who metabolizes codeine to morphine and how much morphine gets metabolized. So for the 10% or so of the population that doesn't have very much 2D6 activity, their codeine doesn't convert to morphine, and that codeine doesn't do much for their pain. And that's troublesome, that's annoying. We have to go to a different analgesic. The patient is uncomfortable for a period of time until we find something else that's going to work for them. But what is more concerning is, and has been observed in both older patients and younger patients, is that some patients actually have a lot of conversion of codeine to morphine and actually develop respiratory depression or respiratory arrest. And so codeine is, because there is so much pharmacogenetic variation in codeine response, codeine is a drug that is falling out of favor because of this wide pharmacogenetic variation. So important to sort of recognize that variation happens, and so you may want to consider not doing that. Okay, one other issue here is it's sort of anecdotal but important to think about, is think about yourself, and if we were in a classroom together and by show of hands, ask you as in the class who has had asparagus urine. And if you've ever had asparagus urine, you know exactly what we're talking about. Asparagus urine is kind of a sulfur-smelling, rotten egg-smelling urine a couple hours after you eat asparagus. Some people have it and some people don't. And here's an example of classic genetic variation in metabolism. And it illustrates the point of something called polymorphism. Polymorphism is the expression of enzymes which metabolize, in this case, as we apply the concept of polymorphism to drug metabolism, is the expression of enzymes which metabolize drugs are different in different individuals. And it means that some people will metabolize drugs really quickly, some won't metabolize it at all, or some may eliminate it by a different process entirely. So here in a population where almost everybody is blonde, there are a couple of redheads in the group. True, the redheads may represent a subgroup of folks who have either excessive or very limited ability to use that enzyme in drug metabolism. So this genetic polymorphism, let's sort of look at this in the concept of asparagus again. Folks who ingest asparagus, this may or may not have asparaginosic acid in asparagus is metabolized to at least 6 different sulfur-containing alkyl compounds. But it's also metabolized to other things that don't contain those same sulfur moieties. And so depending on which enzymes you have, you will find that those metabolic byproducts of asparaginosic acid are going to end up in urine. And the ones that end up in urine that smell like sulfur mean that you have a certain metabolic process genetically to metabolize this, where other people may not. So here is a study of 800 volunteers in the United Kingdom and looking at who had asparagus urine and who did not. And your first thought, and this is many, many years ago, and your first thought is, boy, they pay people to conduct studies like this. But what's important to recognize, at least in this study, is that in the United Kingdom, there was a variation in people who had asparagus urine and people who did not in their volunteer cohort. This is very early, this was before sort of we had sequencing of DNA done. And they did a similar, smaller study of volunteers in France, and all of those folks had asparagus-smelling urine, which suggests that in each of these cohorts, maybe there was a difference in response based on the way these folks metabolized their asparagus. Now, truth be told, there could be other explanations for this. It could be that the cultivar of asparagus was variable, that some cultivar of asparagus had a lot of asparaginosic acid in it and another one didn't. So there's other explanations. But I think if you can sort of talk with your colleagues about who has asparagus urine and who doesn't in the room, you'll kind of get the sense that there's a variation in metabolism of asparaginosic acid, like there's going to be a variation in how different people that you are going to have, different patients you're going to have in practice are going to have variation in response as well. Let's look at a couple of examples of some key pharmacogenetic variation we'll see in drug metabolism. One metabolic process, which is a phase 2 reaction, evolves around acylation. And this was one of the first drugs where we recognized variation in drug metabolism back in the 1970s, the 60s and 70s. And it was kind of identified with a drug used for treating tuberculosis or preventing tuberculosis called isoniazid. And what they noted is that there were some cohorts that, some subset of folks who were considered slow acylators and others who were considered rapid acylators. Folks who metabolized things slowly, maybe they didn't have much of ability to metabolize isoniazid. And those who were slow acylators were more likely to have the side effect of peripheral neuritis or potentially even the risk for SLE, systemic lupus erythematosus, with other drugs because of their slow acylation process. The rapid acylators, on the other hand, generally required more drug to achieve the same therapeutic response, and the amount of metabolite that they produced posed a higher risk for hepatotoxicity, hepato meaning liver toxicity. And so there are pharmacogenetic variations in the ability to metabolize drugs, and that can have impact both on whether that person needs more or less drug, but also whether there's a metabolite associated with that process that leads to potential toxicity. There is a neuromuscular blocker that is occasionally used. It really is used in intubation, called succinylcholine. It's really primarily only used when we're intubating patients because it's a very rapidly acting neuromuscular blocker. And this agent we're going to use and administer when we're intubating a patient. As we're putting a tube down to help them open their airway, it is going to make their muscles blocked so they won't fight that intubation. You won't have a patient fighting or tearing. But the problem is you need to get an airway in right away because they're not breathing either. Most folks, they will clear by enzymes, pseudocholinesterases in the blood. They'll clear most of the succinylcholine within 5 minutes or so. So after you've intubated the patient, this neuromuscular blocker wears off. But the problem is that in one in about 1,500 patients, they don't have much of that pseudocholinesterase, and so the duration of the succinylcholine isn't 5 minutes, it could be hours. And so you need to recognize there's going to be variation in that response. We've long known variation in the ability of patients to metabolize ethanol or alcohol. There's a genetic influence for that, and the kinds of responses to ethanol as well, the degree of facial flushing, the degree of elevated heart rate, diaphoresis, muscle weakness, is going to be indicative of their ability to metabolize with alcohol with aldehyde and alcohol dehydrogenase. We already talked about the P450 with codeine variation. That's a concern for us. Here's a study that looked quite a while ago, but it demonstrates the overall principle is that there is, in certain populations at large, a large variation in the ability of certain enzymes, isoenzymes of cytochrome P450, and it varies both by cultures or populations. It also varies within that culture or population. So within the Northern Europeans, there's going to be variation in each of these. Within the Southeast Asian population, depending on which particular community you're looking at, it's all going to be related to some generic variation within that as well. We also think about the concept of toxicology, and we alluded to this already, if there is a toxic metabolite in one particular process. And so drugs that are metabolized by enzymes with genetic variation are more likely to result in drug toxicity than drugs that don't have a lot of metabolism with drug variation in drug metabolism based on genetics. So here's a study that, again, almost 20 years old, almost 2 decades old, but enlightening in that it looked at toxic responses to drugs linked to genetics. And that for drugs that had a high degree of variation in genetic enzyme metabolism, those drugs were 8 times as likely to produce adverse events than control drugs were. And so important to recognize in practice that this genetic variation poses a risk that there's going to be some patients who fall out of the norm because there's going to be a wider variation in that response to drug therapy. We see other toxic responses linked to genetics. For example, in smoking, smokers have a lower birth weight, but it's a function also of the amount of birth weight, and smoking varies depending on the amount of cytochrome P451A1 that the mother has genetically available to convert toxins in cigarette smoke to inert substances. So there's going to be variation among all women who smoke. Some are going to have a more likelihood for a lower birth weight or potential harm to the fetus than others. Fetal alcohol syndrome, also the risk is genetically linked. There are many drugs in clinical practice that undergo or are affected by genetics, either in drug receptors and or in drug metabolism or clearance. And so there are many of them, most drugs we use in practice now have genetics have some influence, but some much more than others. So we'll talk more about this as we get later in the year, but I want to sort of have a placeholder here for you to be able to think about that. And so finally, just recognize that not all patients will respond to drugs in identical ways, that genetics is probably the largest influence here for that, but also differences in organ function, differences in weight, in fluid status. All of these factors will affect how someone may respond to drug therapy in different ways than a different patient.